space. That space will naturally lift the patella up. So historically, the patella sits in the patella groove, and it's absolutely solid in its groove. It's bone on bone with the thickest cartilage in your body, sitting in a facet, everything's cool. When the swelling's there, it pushes up the patella, and as you push down the patella, compared to the contralateral side, you feel that it's not in contact with that bone, so you get a tap. It feels like you're tapping, because in essence you are tapping. And so you're coming up, you're taking your time, you're coming up, you're fixing that swelling, and you're using your thumb to push down and feel that test compared to the contralateral. So number 1 would be 1 mark, and number 3 would be perfect, and then of course in the middle we're always going to get somebody who's done it well that might have missed a tiny element, in which case you wouldn't get the 3 marks, you get 2. Collateral. So you see all kinds of people coming in to do collateral, and it's quite awkward, and you can see that people are finding it awkward. So tip for you, think about what you're testing. So there's only one ligament in your knee that has 2 parts, a superficial, which is active from 0 to 20, and an arcuate, deep part of the ligament. By arcuate, I mean the fibres are shaped like an arc. So anywhere through that range, you're getting a contralateral stiffness on the inside. You're stopping the knee going in, and so you need to test these in 2 positions. So if you've got somebody who's big, or you are small, the way to do it is pop it on your hip. Pop it on your hip. So here, I'm not holding his leg anymore because he's just sticking the leg on the hip. And what I'm doing is, I'm pushing in, not like this, you see people going like that. The patient will just tell you, fuck off. They just get up and walk off if they're an athlete. So getting hold of them, here, push. Nice strong push. 20 degrees, push. Conversely, just relax for me. I tend to sit down, because then, again, I don't have the weight of that leg. I'm not using 2 hands to hold everything. I come in this position and I'm applying pressure. I'm not at this. It's very much a controlled pressure that builds up. And what I'm looking for is that sponginess comparative to the opposite side. Right, McMurray's test. You remember McCarthy's test where we go in all the way down the hip, come out all the way down. Now, the McMurray's test is all about scooping, okay? Imagine that you're scooping. So if I grab the talus, I don't have to, this is really awkward and difficult. I have no control. Here I have much more of a lever. Hopefully he won't have his trainers on when we're examining, but you're coming up into flexion and we're scooping into this region here. You don't have to come into extension. You don't have to extend it, okay? You're scooping in an internal scoop which prioritize, what does it do? Sensitizes the medial compartment. Conversely, I scoop in the opposite direction and stress the lateral meniscus, yeah? So think about, you've got a tear or you've got a disruption in that, and all I'm trying to do is brush it and then turn it the other way. Okay, so you don't have to come around, it's just a nice circular scoop in this direction. Because once you're here, there's very little compression on the meniscus. Yeah? Once you're here, then you're compressing the meniscus because the joint is closing and the joint pressure, the femoral condyle, the tibial plateau are being opposed, and the sandwich in between that is the meniscus, and you're looking for a defect in that meniscus. The other thing about the joint margin tenderness, there's lots of research to say that this medial collateral ligament, which is the most commonly torn, 80% of the time, hits the MCL as ligaments called coronoid ligaments. That coronoid ligaments stick it down and stick it to the MCL. So the reason we go and we do this joint tenderness is we know it's very much linked to a combination test between that and McMurray's, okay? We also, obviously, are going to come on the outside. So if you and the OSCE got a positive McMurray's internal rotation plus medial joint margin tenderness, you're probably looking at a medial meniscal problem, yeah? Conversely, if we've got an external rotation and then a lateral joint tenderness, then that's the converse. We're looking at a lateral. Yeah, we happy with that? Anterior cruciate. So Lachman's, awkward. If you're small and they're big, really, really awkward. So make it easy. Put their leg on your leg. That way, if you've got big enough hands, you're going to wrap your hand around here and you're going to translate that. If your hands aren't big enough, you're going to fix that, and then at least you can purchase from underneath. Yeah? So if your hands are big enough, they go round, and it's very much that. And if you're not big enough and they're bigger than you, then it's fixed against your leg and it's an anterior movement on there. Yeah? Benjini? Anterior draw. Same again, don't do this. That means nothing. Like, all they're going to do in real life is their hamstrings are going to go into spasm. You're not pulling my leg because it hurts. So you've got to be gentle, and what you're trying to do is look at your thumbs. Okay, they're not going to be in a pair of trousers. You look at your thumbs here, and you're looking and feeling that translation comparative to the other side. Like so. Where am I? Where is sag sign? Bend this knee, sir. Very much a sign and not a test. So you're looking for a transitional step. So as you look from the side, you would see an offset tibial plateau. So that's your knee. You'd see your tibial plateau sag back because it's got no constraint to go backwards. So you'd see a step in that. Conversely, obviously you're going to see as you push back, you're going to get more translation posteriorly than the contralateral side. Ooh. This is what it wants. This absolutely does what it wants. Where are we? Patellofemoral. So the reason we go laterally is 90% of all patellofemoral dislocations occur laterally. You can do a medial glide, but most of them go that way. You come out this way and you end up tearing what's called your MPFL here, your medial patellofemoral. So what you're doing is knee in a good position, nice and straight, and you're taking that medial patella and you're gliding it, and there should be really virtually no movement. If you start thinking that's going way too far, it feels obviously it's a concave in a convex, and it should stay. If all the ligaments are fine, it should stay concave in a convex. If it starts to come up the other side of that hill and feel like it's going to move, and they say, "Oh, I don't like that, stop that," then we know that that's a positive apprehension test. Yeah. Brilliant. Nobles is all about getting the distal ITB, and it's a distal ITB friction band syndrome. So you have the band going down, you have a little bony protuberance, and underneath that you can have a bursa. And what we're interested in, and I don't care, some people you watch a thing and it says do it passively and do it actively. You're really interested in the terminal about 40 degrees because it's when your knee is straightening and the band is becoming tight that's important. So again, can you bend your knee up slowly for me? And then straighten it out. But when you get hold of them, just get hold of them like you mean business. Yeah? Not like, lift your leg up, mate. Drop it down a bit for me. Okay, just lift it up. Just drop it down. You've got to get hold of this and go, right, okay, what you need to do is straighten your leg nice and slow. There we go. And bend it for me. Cool. Ober's test, that way for me. Now, okay, no? There we go, this one. Don't worry. Ober's test, crappy test. Bring that leg up to his chest. You'll see different versions of it. You'll see both legs being straight and then extending it and dropping it behind. You'll see people tucking up to make the pelvis square. The way we do it is tuck up, and that neutralises your pelvis, allows you to give you a hand. You'll see people use a straight leg and a bent knee, okay? And I don't care which one you use, they're equally shit. So, and then what I want you to do now is just bring your leg back for me. Now the important thing here is that you're fixing the pelvis. Because anybody can do that, because all he does is does that, okay? So you've got to fix. And if you're using a straight leg, just let that drop for me. Let that drop. Brilliant. And the bent knee, and let that drop. So they go. Yeah, don't care whether it's straight or bent. Is what it is. You can sit up, sir. Anybody got any different ideas to that? Anybody got anything to add to that?
Just for the McMurrays, those
Yes.
are the ones where they do the kind of internal and external rotation to be able to straighten the leg out. Are we okay?
Into full extension.
Into full extension, rather than
You are. In all my career and all the people I work with sports stuff wise, we never go into full extension. If you've watched that and you're comfortable with that, again, I don't have a problem because you'll see people do it in a different way.
I just mean it more in terms of like the rotating and just doing the small extension rather than doing the scooping?
Okay, just to go back how I do it, so this is how I do it. I kind of scoop because it's like I was taught to do it in a circular fashion, which means you're covering all the meat, and then as you turn, you're scooping again.
Right.
And what you're saying is
they essentially do the turn that you do in or out, and then they just
and then straight out.
Yeah, like that, and then just go back and forward
Yeah.
like that.
In reality, all the positives Murray's tests I've ever done have been very much in that
First one.
deep flexion, because that's very much where it's in what's called the close pack position, so the joint is very tight. As you come out of that, there's not much pressure on the meniscus. But again, if you've seen that and that's how you've been taught at medical school, I just don't have a problem with it. It's not a big deal.
In terms of pathologies, will it be multiple positive
Yes,
things?
always. Yeah, of course. It's unfair. Yeah, it will be barn door stuff. It'll be a positive It'll be a positive sweep, a positive Blackman's, a positive anterior draw, a history of locking giving way following a violent twisting action that occurred with swelling immediately after the injury.
No, as in, will you get something like ACL and medial meniscus?
No.
Okay, it'll just be one thing.
No, because to be fair, they come together. But again, it's not fair to do that with you guys because we have surgeons. So I've done this job 28 years, and I still think, oh, that's an ACL. Someone will come in and go, that's a barn door ACL, and they'll go off, and it'll be a meniscus. And then somebody will come in where I'll go, I think that's a meniscus, and I think it's not giving way. There's no locking. It's good in extension. They'll go over an MRI and it's an ACL. And surgeons now, they'll do an examination, but they'll always just send them for an MRI, and they'll say, well, I think it's an ACL. I'm almost sure it's an ACL, but we'll get an MRI because it is sometimes really difficult. Like people don't conform sometimes. How you think they might. It's the history with an ACL is the biggie for me.
Which way during McMurray's is internal rotation?
So medial is so that is internal rotation.
So when you're going like into your
Yeah, so if my toe is pointing in, the load is medial. If you imagine your knee joint. Is there a knee over there? Is there a knee at the back of there? That's his one, mate. Don't throw it. Yeah, so if you think about this, meniscus. So that's my tibia. This is a right leg, yeah? So as I bend this knee and I do that, most of the friction and compression is loaded through the medial compartment. Imagine that's my foot goes in, so my tibia goes in. If I use my foot and ankle, if I use my tibia, I really struggle to hold it. Are you alright laying down again? Sorry. So if you think about me doing this and holding it, you've been cycling, you've got a bit of oil in your leg, mate. If I do it here, it's just really, really awkward. But if I do it here, I'm using the mortise joint of his ankle. Because his ankle doesn't rotate. Ankles don't rotate. They don't have that movement. So now already, I've got control of the tibia because I've got this joint that doesn't really rotate. And now, I can rotate however I want to do it. And then out, conversely, stresses the lateral compartment. Yeah?
You kept on referring to comparing it to the other side. Am I right in saying we might not always have time to do that in the actual thing?
Yeah, I think we've discussed that in most sessions, haven't we? So from a perspective of, we might start off letting you just have a quick look at the other side and come back. But we're mindful of time, and we're mindful we've got a limited amount of time. So you've got 5 minutes left and you've got 3 things to do, we might let you do both sides. But if you're time-wise, we'll always kind of go, you've checked that, move on. Because if you're taking your time and your time's ticking away, we go, just focus on the affected side. Don't focus, and you'd say, well, I'd normally examine the other side. Take it that you've examined the other side and we'll tell you what the response is on the side you're testing. Yeah, we'll always do that. That's something we're all primed with right from the beginning. So the take-home things here are, it's about getting your handling right, and that takes practice. Yeah, it's about how you grab hold of something that you have control of it, and the leg's not wiggling about all over there, and you're not testing what you're supposed to test because you're getting that one mark because you're talking about a test, and you're telling us what it is and you're having a go at it, but it would be ineffective in the real world. You wouldn't elicit a response in the real world. And 3 is you're doing it right, and actually this thing would work if you're doing it on a real person with that problem. And then there's a grey area in the middle where perhaps you're quite good, but you didn't get part of it, or you didn't do it at the end of range, or you didn't do this, and it's a sliding scale. Cool.